Hi everybody, welcome to my channel. I'm Stacy, I'm a registered nurse. If you're new here, welcome in. If you're coming back, I'm so glad to have you. Let's continue to talk about hospice. I talked about becoming a hospice nurse. Let's talk about symptom management. Let's talk about symptoms that hospice will help you manage. If you're curious about that and you want to learn more about nursing or hospice or any of the things that I've talked about, that I encourage you to like, subscribe, and follow for more. Let's get into symptom management. What are some of the things that we do in hospice to manage symptoms? Have you ever wondered what a hospice nurse does, what a hospice CNA does, what each member of the team does? I will talk about those things in other videos because I think it's really important that you understand the roles of a hospice and what hospice can and cannot do. For hospice, we have different components of symptom management, and it's not available in every area, unfortunately. Hospice can manage symptoms in the home. That is our primary goal, is to manage a person's symptoms at home and allow them to pass peacefully at home. But we do have other types of hospice areas of care. So one of the things that we do in hospice is called GIP, which is general inpatient. That can take place in a hospital and that can take place in a hospice facility. There are hospice facilities, hospice houses, if you will, where they manage symptoms that are uncontrolled at end of life. There have been patients who pass in a hospice facility as a general inpatient, and sometimes those symptoms cannot be managed at home, so they must be managed in a facility. And whether that would be in a hospital, a nursing facility, or a specific hospice inpatient facility, that is one of the things that hospice offers. Some hospices offer continuous care where they have a nurse or nurses dedicated to coming in and staying with a patient to get their symptoms managed at home until they are at a managed level of comfort. And that includes like administering medications for comfort. And then we have your routine home care, which is where the nurse is coming in to visit weekly, bi-weekly, 3 times a week. And of course, as things progress and the patient is beginning to transition to end of life, the nurse is coming daily. The CNAs are sometimes coming daily. You have social workers, chaplains that are all managing different symptoms for the patient. So what we're thinking about in terms of nurse management for symptoms would be pain, anxiety, restlessness, nausea, vomiting. Wound care is something that nurses manage at end of life, because as things transition and progress in end of life, sometimes the skin will break down, and so the nurse will have to manage wounds as well. The most common things that we're managing, though, are pain, shortness of breath, anxiety, agitation, nausea and vomiting. Constipation is a symptom that happens at end of life. Those are things that nurses are managing. What kind of medications are we using to manage those things? We can talk about medication management first, but there's other ways that you can manage symptoms as well that are not medication induced. And some people are very uncomfortable with the idea of hospice medications and symptom management. But the medications that are used in hospice are designed to bring comfort, not hasten death. The dosages that we give to patients in hospice are not significant doses. Initially, we titrate up as the patient needs, but you're looking at, say, 5 milligrams of morphine every 3 hours, for example, sublingually, under the tongue, or in that pouch between the cheek and the gum. Every 3 hours, 5 milligrams. And your morphine, your liquid morphine, is a short-acting med. So it is going to act quickly, but it's also going to get out of the system quickly. So it's not great for long-term management of symptoms. But say somebody has COPD, which is chronic obstructive pulmonary disease, and they're short of breath. Well, morphine does help relax the breathing and slow the breathing down, so that a person with COPD utilizing morphine would be beneficial to help them have a better quality of breathing, to help their breathing to relax and calm down. Another thing that morphine is used for, of course, is terminal shortness of breath, pain. When a person is actively dying, They can't always tell you that they're in pain or that they're having discomfort. And some of the medications that were working when they were able to swallow medications are no longer going to be effective when they're dying because they can't swallow anymore. And the comfort medications that we use in hospice are designed to absorb through the blood vessels in the mouth, and they do not need to be swallowed. Of course, if a person can swallow, they should swallow their medications, but the medications are designed to be given under the tongue. We have little blood vessels under our tongue, and the medication gets rapidly absorbed there. The best. Also, if a person, you're not always going to get under a person's tongue when they're dying. Sometimes people clench their teeth and they don't want you to put something in their mouth, even if it's going to help them. And if they're comfortable, I would say you absolutely do not have to use those medications. Some people never open their comfort kit. Some people are comfort throughout the dying process, and they have nurse visits and they have, oversight, but they never use those medications. But generally, at end of life, another thing that we manage is oral secretions. So you and I swallow several times a day, and when you get to end of life and you're no longer swallowing, you also don't swallow your saliva. And so that you can have excessive drooling and need something to control those secretions as well. I used to not feel as comfortable with morphine, but I always gave it as directed by the hospice nurse when I worked in a facility. But having seen the change that it makes for people, I can tell you that it can add a better quality of life to someone, and I just haven't seen the dose of morphine that we use really knock somebody out. Some people are worried about their family or their loved one being sedated. But I would also like to say that when you get to end of life and your symptoms are not well controlled and you're uncomfortable, that being awake and uncomfortable is not a very good process either. So sometimes the dosage that becomes required at end of life is allowing a person to sleep through those symptoms that they're having, and they are resting comfortably, and that is the goal in hospice. And this sometimes, death and dying can happen for hours. Sometimes it can take days for a person to die. Sometimes a person can be dying for weeks. That's a very real possibility, and I think it's important to provide that education when you're talking about symptoms and death and dying. And we can also talk about what those symptoms that death is near look like in another video. So the other medications that we use besides morphine, we use things like hydromorphone or Dilaudid. If a person, for example, is allergic to morphine or they don't have a good response to morphine, we very seldomly use fentanyl patches, because a lot of times people who are at the end of their journey are very thin and bony, and fentanyl patches work best on someone who has a little bit of fat to absorb the medication into. If a person is thinner, they may not get the benefit from using a fentanyl patch. Sometimes families will ask for fentanyl, and there are a lot of options that you can use for medications, and I'm just talking about a few of them. We have used fentanyl patches in patients that are not as thin and have a little bit more fat to absorb that if they are not getting pain relief. We use long-acting morphine for people as they're going through their journey. If you find that you're giving somebody a pain medication every 2 hours, then you can say probably their pain is not well controlled. And our goal would be to give them a long-acting pain medication then, like extended release morphine or extended release OxyContin, or sometimes we use methadone in hospice for someone that has been on opiates a long time and they're just not getting relief from their pain medication anytime. Because when you have cancer and you've been taking pain medications a long time, you begin to develop a tolerance to those pain medications, and they begin to not be effective on managing your pain anymore. And managing things, there are so many different types of pain that you can have in hospice. We manage nerve pain, bone pain, pain in your muscles. So there are different types of pain medications that can be used to give someone relief when they're battling their specific disease process. Every person's disease process is going to affect them differently. But cancer is especially challenging when you start thinking about metastasis, bone involvement of other organs, and how they're absorbing those medications. So we do use things that are longer acting in hopes to give someone with cancer, with bone pain, some relief. Because if you're up battling your pain all night, you're not going to be able to sleep, you're not going to be able to eat, you're not going to have a good quality of life at the end of your life if you're constantly in pain. So one of our goals in hospice is to keep somebody symptom managed the best that we can. And sometimes getting those medications titrated is quite a process, because what works for one person may not work for this person. But that is the beauty of hospice palliative doctors, is that they have other recommendations and things up their sleeve. If this isn't working, then this may work better. And I worked with a hospice doctor who really had a great knowledge of how medications were absorbed, and he was very good at dosing cancer patients versus someone with COPD or someone with heart disease, because the symptoms are going to be different for each disease process at end of life. Some of the things that we manage too would be anxiety, agitation, restlessness. At end of life, people get anxious. If you can't breathe, if you're in pain, if you're worried about your dying process, your mind just can't shut down. You can't get sleep, you don't get comfortable. We use medications to manage anxiety at end of life. And two, when you're at end of life, sometimes there's something called terminal restlessness, and you will see where a person they're constantly fidgeting, they can't get comfortable, and no matter what you do, it's just not helping. And when you get that lorazepam or alprazolam on board, then they are resting. And also we use clonazepam sometimes, depending on the need. Lorazepam is a little bit of a faster, shorter acting medication. Alprazolam stays a little bit longer. And then your clonazepam really is a longer acting anxiety medication. I love that my doctors are good about educating families too. They will talk about the risk versus the benefit of taking each different anxiety medication. If you have somebody that's up and walking, you just need to be aware that when you're giving certain medications, it's going to increase their risk to fall, unfortunately. Because the medications don't necessarily make them sleep better. They're still going to wake up, and they will be potentially impaired from the medication to where they're not going to be able to walk without assistance. And a lot of our patients are older and have a little bit of memory loss, and they forget that they can't do those things. So it is a fall risk to give the medications, and it's important that you're educating your families about the risk versus benefits too, so that they can choose how to proceed. Most of our doctors start with a low dose and titrate up as the patient is showing tolerance for the medication. Our doctors like to change one medication at a time so that we can see what's working and give it time to work. We usually like to check on the patient every 24 hours in increments until they begin to get relief from those symptoms more so. Another thing I talked about was agitation. Sometimes in end of life, people get agitated and or aggressive. They will strike out. They will have hallucinations, not induced by medication necessarily, and also sometimes nausea and vomiting. So something that we use for agitation and restlessness in hospice is Haldol or haloperidol, and it is an antipsychotic medication. And a lot of times people will hear that word, antipsychotic, and they will hesitate to use the medication. But the second they bring Haldol on board, the patient suddenly has immense relief from those hallucinations or the agitation that they were experiencing that was making them aggressive. And Also, Haldol can be used to help with nausea and vomiting at end of life. It acts on a different mechanism, and sometimes nausea and vomiting is caused by different things related to your disease process. We also use Compazine and Phenergan and Zofran and all of those types of medications for nausea and vomiting. Everybody's disease process, again, is different, and they respond to different things. You know how you feel when you're nauseous or you're vomiting, and so it's important that we get those symptoms under control as well. But another thing that leads to all of those symptoms, anxiety, agitation, nausea, and vomiting, is constipation. And having regular bowel movements, even if you're not eating every day, is still important at end of life. Again, our goal is not to end life or hasten death, but to make someone comfortable. And if you can't go to the bathroom and you're constipated, then you're not comfortable. And it can bring on nausea, decrease your appetite. It can make you anxious, restless. I mean, you know how you feel when you're bloated as a person. So just think about that. If you can't express those needs, you're not eating, but you need to go. You know, sometimes you still need to have a bowel movement. And that is a very important part of symptom management. Also, as a hospice nurse, it's important to begin a bowel regimen if you're utilizing comfort meds for pain management. Tylenol can cause constipation, and especially if you're using opiates, it's going to slow down the motility, and you definitely need to have a bowel regimen on hand, and that would look like a stool softener, laxative, something. If the laxative isn't working, say like a suppository, we use things like milk of magnesia, bisacodyl, Senecot, docusate sodium. We use lactulose, that's the super bomb, and we use Miralax. We use things of that nature to help with the bowel regimen. Then we have, I talked about nausea, I talked about the medications that we use for nausea. We also have secretions. So at end of life, sometimes you can't clear your secretions, you're not swallowing. Positioning is really crucial for that in end of life, and a lot of times it's not causing the pain or discomfort that it appears or sounds like it may be causing. A lot of times the medications will dry up those secretions, but they can have other side effects as well. So a person who's alert, you want to be mindful of using those types of medications. We use the scopolamine patch, the transderm patch behind the ear. A lot of people have used that when they go on a cruise, get on an airplane, get motion sickness. That's a common one. We use hyoscyamine. If I'm pronouncing these names wrong, it's just the way that I've learned to pronounce them. And we use, my brain's not going to let me remember it now, but we use a lot of different medications for secretions as well. There's a more common one that we use that has less side effects, and we have a tendency to use those when a person can swallow. Hyoscyamine has some effects. They're anticholinergic, and they will dry everything up, and they can increase drowsiness and dizziness, so just be mindful of that. Of course, if a person is not swallowing, hyoscyamine is going to absorb under the tongue. Your transderm patch will go behind the ear, and you can change it out every 72 hours. So you want to take it from behind one ear and put on a new patch. Always when you're talking about patch usage, you want to make sure that you're removing the old patch and putting on a new patch. You don't want to leave the patches on, because you can have an added effect and cause unnecessary symptoms for patients. And that includes your pain patches and your scopolamine patches. Any of those things that you're putting on need to come back off. The scopolamine patch is every 72 hours. Your fentanyl patches are every 72 hours generally. And your lidocaine patches are something that people don't realize, but you need to remove those after 12 hours. They're effective for 12 hours on the body, and they come off for 12 hours, and then you apply a new one. So it's really important when you're thinking about symptom management that you're also remembering to remove the old patch and put a new patch on. And you would be surprised how many times you would find a patch that hasn't been removed. So when you're doing your assessment of your patient, it's really important to be aware of where those patches are sitting, and that if you are involved in the changing of those patches, that you are removing those patches. And if you're not involved in the changing of those patches, that when you're doing your assessment, you're giving good education to the family about removal of those patches. So that is the kind of medications that we use in hospice. Also, people take their regular medications a lot of times. We let people continue to take their routine meds as long as they're receiving benefit from it, as long as they're able to swallow and able to take those medications. It used to be when I started in nursing 20 plus years ago that everyone who would come on hospice would stop their medications, and it was just then a waiting period until they died. But it is just not like that anymore. Sometimes we have people living longer, and even though they're having decline, they're still continuing to take their medications and get the benefit from those medications, such as blood pressure medications, heart medications. One of the things that we do look at when we're talking about medications in hospice are anticoagulants, antiplatelets, medications that slow clotting time, or medications, we call them blood thinners, but that's not really what they do. Each of those medications has a different function. That would be things like Eliquis, Xarelto, Pradaxa, warfarin. Those are the types of things that we're looking at generally when we're looking at a medication that a person is on. Plavix. So each of those medications has a different mechanism to, help prevent blood clots, help prevent stroke occurrences, help prevent DVT, the deep vein thrombosis. They have a function to prevent clots that can hasten death, right? If you have a blood clot, if you throw a blood clot, it hastens death. But you also need to think about a person maybe who is falling all the time. And on hospice, we're generally not doing something like managing warfarin, because you need to be monitoring PT-INRs regularly, and managing that from home in a hospice setting can be a little bit tricky. It's not that it's not ever done, but it is a little bit more challenging, and it is not recommended. Usually when we take someone on hospice, we would stop something like warfarin if they're wanting to continue to take their anticoagulants and change it out for something else. But you just have to be mindful that if somebody falls and they hit their head, they can get a bleed, and that can hasten death as well. So you have to think about risk versus benefit when you're thinking about hospice and medication management. And so those are just some of the things that I think about when I'm going into a home and I'm looking at medications. Also, when you're going into a home as an RN case manager, you should be reconciling those medications every time so that you're aware of what your patient is taking. Sometimes our patients are even still going to the doctor. They're going to different doctors that have nothing to do with their current diagnosis. And they're still going to see, for example, their urologist, or they're going to see their dermatologist, and those doctors are prescribing medications. So it's really important when you go into your patient's home that you're always asking if any medications have changed, that you're always looking at their medications, you're always looking at the expiration date of that comfort kit. What is the comfort kit? Did I talk about that? So a comfort kit is something that comes to the home when a person signs on to hospice. It's your emergency kit that you have for 2 a.m. It's really important that you make sure as an RN case manager that your patient has a comfort kit on board. Even if they're not at a point where they're going to need that, it seems like it always happens that they need it in the middle of the night when you can't get it as easily. Some hospices have an after-hours emergency delivery service, but a lot of hospices don't have access to medication delivery in an urgent stat kind of way. We can prescribe medications to 24-hour pharmacies a lot of times, but then the family has to get out and get that medication, because a lot of times as hospice staff, as caregivers, in hospice, we cannot even bring those medications to the family. It depends on the policy of your company, obviously. I have worked for a lot of companies that do not allow you to handle medications, and you need special permission to go and pick those medications up. It's a lot of red tape sometimes. So you do want to make sure you have a comfort kit in the home, and at minimum it needs to have morphine, lorazepam, haloperidol, compazine, bisacodyl, and a Tylenol suppository. That's pretty standard in a comfort kit. Now, when you think about comfort medications, you also, when you're bringing someone on hospice, again, you want to make sure that they have a bowel regimen in place, especially if they're taking pain medications routinely, whether that be Tylenol or opiates. Our patients need to have a bowel regimen, and they need to have bowel medications on board. But it's really important that we get those comfort kits in the house, and that is a big part of symptom management, because a lot of times families are going to call at 2 in the morning because mom or dad or grandma or grandpa is short of breath, they can't get comfortable, and they're going to be walked through how to use that medication on the phone with a triage nurse until a nurse gets there to assess the patient. Also, as RN case manager, it's really important that you're going through those comfort medications and how to utilize them, that you're showing them the bottle, that you're explaining these things as you go through their care. A visit is not just checking vital signs and, going on about your day. We are really there to provide good education and symptom control to our families, and that starts with education. Symptom management starts with education. They're not going to remember everything you say every time, but if they call the triage nurse and they've been hearing you talk about it, it's going to trigger that education that you're providing. And that's really a big part of symptom management, is education of your family. So those are some of the symptoms that we manage in hospice. Those are some of the medications that we use. What are some medications that you use in your hospices? What are some things that you've heard for symptom management? Maybe there's something that I don't know about that would benefit my patient. I'd love to hear about it in the comments, and I would love to hear more from you. So if you like what you see here, then I ask that you like, subscribe, follow, and comment for more. I thank you for watching, and I hope to see you soon.